So when we talk about patient education, where does it start? It starts with learning the 3 phases of healing. You can't educate somebody on something you don't know. You can't sell something you don't know. Sell something means ask for money in exchange for, ask for time or money in exchange for what you're doing. And that's really where the problems start, to be honest with you. I don't think I have anybody who understands this and knows this that has trouble with patient education. Even the way we do money, because we'll make money affordable, where it's affordable. We always, I've never turned a patient away from care in my whole career. Never. We make it affordable. So we pay a lot of attention to this, the need, the time, and the money, and that's good business. And we'll see a lot of patients, and we'll do well. We'll help a lot of people, and make a lot of money. That's the byproduct of giving a good service. You make good money. So let's go into this. What I did is there's the full-blown version. So if you Googled wound healing, that's what it's under. If you Googled and go under the Wikipedia, that's when it'll read like a physiology book like your freshman year. I mean, it is not easy reading. It's complex medical terms, but that explains it. That explains the physiology in detail of the 3 phases of healing right there. Okay? Now, what I did is I simplified it. I took it and I put it into a simple outline form. That's what this is. So it's still a little more complex, and I'm going to read through it here a little bit just so you can see what we're dealing with. But you have to read the original one. The more understanding you have of the 3 phases of healing, the more you'll be able to explain it, communicate it, and believe in what you're doing. Okay? And that's the number, patient education all starts with what you believe in. So the very first thing, that's what's so great about the 3 phases of healing. I'm not trying to teach chiropractors a philosophy or a certain way to do something. I'm like, 3 phases of healing is the way it happens no matter if you do Gonstead, no matter if you do CBP. It doesn't matter what you do. 3 phases, and it doesn't matter who they go to. That's how they're going to heal, period. So that's why it just made sense to me. It's not like unique to me. I'm like, no, that's the way you're going to heal no matter what you do and where you go. And then I'm going to apply it to my education and my therapeutic protocol. And you'll see why it fits with chiropractic fantastically for these injuries. So here's what I want to do. I'm going to go through the outline version first, and it's going to get a little boring. But you got to kind of look at this. You got to go into the background of this a little bit more. Especially when we start paying attention to the test. You go, well, what tests are going to show these or not show them? Are you doing the right test? Well, we got to get you to do the right test to see the right problem. And then you go, well, what therapy are we going to use? If this is what's positive, what therapy are we going to use that affects that physiologically with what we're trying to do? See, that's how it all matches up. How much sense does that make? In other words, you should have learned this before you graduated, right? They should even have given you your degree, should they have, without you knowing this. But unfortunately, that's not the case. So let's go into the outline version. It's a little more complex. Then we're going to go into the very minimized version. This is where we're going to dumb it down. And then we're going to use this with the patient education. So you need to read all 3. You have to know that, and we'll go into how to do it. But you got to have a deeper understanding. 3 phases of healing is way deeper than this, is my point. So if you never read or get an appreciation for the detail of the 3 phases, you're not going to have as much conviction or belief in what you're doing. So let's go ahead into this, then let's go into that, and let's go into maybe some common tests, depending on what kind of time we have, okay? So here we go, 3 phases of healing, and I'm going to comment appropriately. So I did, just so you do know, Well, I did take this and I packaged it a little bit easier to understand. And I'll make comments about that as we go through, okay? All right, so here's the 3 phases of healing. Number 1, there's the inflammation phase. Number 2 is the repair phase. Number 3 is the remodel phase. Those are the common phases of what they're called, all right? The physiology of the science of the 3 phases of healing. Okay, so the inflammation phase. Now, remember, this is more medical, so we're going to hear some medical terms here. Fighting infection, clearing debris. Okay, next, homeostasis. The healing process, homeostasis. Clotting cascade takes place to obtain homeostasis or stop blood loss by way of the fibrin clot. Chemokines and cytokines are released to attract cells that phagocytize debris, bacteria, and damaged tissue. Chemokines and cytokines are releasing signaling molecules that initiate the proliferative phase of wound healing. And this is important, the proliferative phase. That's the repair phase. The repair phase is also the proliferative phase. This is all going to connect and become very important. You see this little side note I put in here. NSAIDs block cytokines and prevent the proliferative phase of collagen synthesis. I added that. You just need to be aware of that.
I thought that was interesting.
Yeah. This is why before surgery, or especially cosmetic surgery, you're not allowed to take NSAIDs. Okay? But we're going to apply this clinically to what we're doing. So, clotting cascade from clot to collagen. After an injury, blood contacts collagen, triggering blood platelets to secrete pro-inflammatory chemicals. Platelets, along with fibrin and fibronectin, form a plug that prevents blood loss and is the support until it is replaced with granulation tissue and later collagen. Platelets release proteins and cytokines and pro-inflammatory factors like serotonin, bradykinins, prostaglandins, prostacyclins, thromboxane, and histamine. All the stuff that you read about freshman in physiology, bringing back bad memories. So, we're talking about collagen formation. So remember, one of the big concepts in collagen formation is when there's collagen formed after an injury, it's type 3 collagen, not type 1. We are born with type 1. Now there's all types of collagen protein. Collagen's a protein, right? All kinds of different types of collagen in the body. Some specifically for the neuromusculoskeletal system. We're born with type 1 collagen. That's the normal good stuff. When there's tissue damage, is it replaced by type 1? No. The collagen that's regenerative is type 3 collagen. That becomes very important here in just a second. So we got to pay attention to the neurological components and the connective tissue components. Because that's what you're trying to do as a chiropractor. You're trying to affect those. The neurological connective tissue components. Pro-inflammatory factors increase cell proliferation and cause blood vessels to become dilated and porous. Okay, you know that. See, these are divided into categories. So now we're going to go into the vasoconstriction, vasodilation category. Immediately after a blood vessel is injured, cell membranes release inflammatory factors like thromboxanes and prostaglandins that cause the vessels to spasm to prevent blood loss. This vasoconstriction lasts 5 to 10 minutes, is followed by vasodilation. Vasodilation, mainly from histamine released by platelets, also causes blood vessels to become porous, allowing proteins from the bloodstream to leak into the extravascular space, drawing water. So when we're trying to control pain, one of the things we're trying to control is not just the pain signal. What's the other cause of pain? It's the cellular fluid. An imbalance of the pH is a source of pain. It's a pain igniter. That's why one of the therapies, why are we trying to decrease inflammation? That's why. So and we'll go into the sources of pain, but the fluid, in other words, trying to decrease inflammation becomes a major part of therapy to help decrease pain. What therapies are you doing to help decrease inflammation? See? So we're going to be thinking about this on this level. Joint motion, nerve damage, collagen, inflammation, because this is what's causing all the problems, the pain, restrictions, etc. with patients. So that's the level at which you need to be thinking therapeutically. Okay, neutrophils, infection control and injury cleaning. That doesn't affect us too much. Neutrophils are attracted to the injury by fibronectin, growth factors, and kinins. Neutrophils phagocytize debris and kill bacteria while cleansing the injury and secreting proteases that break down damaged tissues. You guys are familiar with that. Neutrophils usually undergo apoptosis, death, once they have completed their task and are engulfed by macrophages. So we kind of know that. That's not applying too much to what we do. Macrophages, cleaning the injury. Macrophages attract. So when you do have internal injury, is there damaged tissue that needs to be removed? Are there damaged cell and debris that needs to be removed? Yeah. That's what's going on here. Macrophages, cleaning the injury. Macrophages attracted by growth factors released by platelets replace neutrophils as the predominant cells. In 2 days after the injury, macrophages' main role is to phagocytize bacteria and damage tissue and debris damaged tissue by releasing proteases. Macrophages also secrete growth factors and other cytokinins that attract cells involved in the proliferation stage of healing. Macrophages are stimulated by low oxygen content of their surroundings to produce factors that induce and speed angiogenesis. We're dealing with several different things here. pH, inflammation, nerves, collagen, vessels. Macrophages also stimulate cells that reepithelialize the injury, create granulation tissue, and lay down new extracellular matrix. This is going to be very important to permanency of an injury. Macrophages push the injury healing process into the next phase. All right, decline of inflammatory phase. So macrophages must be reduced. As inflammation dies down, fewer inflammatory factors are secreted and neutrophils and macrophages are reduced. These changes indicate that the inflammatory phase is ending and the proliferative phase is underway. Remember, what's the other word for proliferative phase? Repair phase. There's a reason they're defined physiologically. In other words, each of those phases are defined by what? What's happening physiologically. That's why it's called the repair phase, proliferative phase. That's why it's called the inflammatory phase. It's because of what's happening physiologically. Same with the remodel phase. So we need to be familiar with what's happening physiologically with these phases, because is that going to be a major component of your therapeutic protocol?
Should be.
Yes. The presence of macrophages delays injury contraction, and so the disappearance of macrophages from the injury is essential for subsequent phases to occur. Inflammation plays roles in fighting infection, cleaning debris, and inducing the proliferative phase, and is a necessary part of healing. Inflammation can lead to tissue damage as it lasts too long. Ooh, how many times do we know to control inflammation? How bad is chronic inflammation? That's a bad thing. We know that because of the physiology that happens. So inflammation's real good if it's cute and short and get over with. Chronic inflammation is damaging the tissue. Well, what's causing chronic inflammation? Well, we're going to pay attention to that. The reduction of inflammation is frequently a goal in therapeutic settings. Inflammation can lead to tissue damage if it lasts too long. The presence of debris can extend the inflammatory phase, for too long, leading to a chronic wound. This is going to be real important as part of a therapeutic protocol and explaining all this to patients. The repair phase or proliferative. Okay, so we're done with the inflammatory phase. A little bit there to ingest. Okay, quite a few. We talked about inflammation, how it affects, collagen, vasculature, pros and cons. Okay, so we go into the repair or proliferative phase. About 2 or 3 days after the injury occurs, fibroblasts begin to enter the injury site, marking the onset of the proliferative phase, even before the inflammatory phase has ended. Now, you see what this says? 2 or 3 days after the injury occurs, fibroblasts enter. Okay, so pay attention to that. We're going to clean this up in just a second. As in the other phases of injury healing, steps in the proliferative phases do not occur in a series, but rather partially overlap in time. In other words, what? This is not black or white. It overlaps. All right, we're in the proliferative phase, and now we're going into angiogenesis. How does the new tissue, how does the new vessels come into that injured area? New vascularization. Angiogenesis occurs along with fibroblast proliferation when endothelial cells migrate to the injury. Angiogenesis is imperative for fibroblasts and epithelial cells that require oxygen and nutrients, and typically looks red due to the presence of capillaries. Stem cells of endothelial cells originating from uninjured blood vessels grow into the injured site to establish new blood vessels. You ever wonder what created new blood vessels in injured areas? Stem cells. You know how big they're promoting stem cells now?
They produce everything, right?
Yeah. Endothelial growth and proliferation is directly stimulated by low oxygen in the presence of lactic acid in the injured. It says is directly stimulated by low oxygen. So decreased oxygen will stimulate the growth, trying to get it to create angiogenesis. That makes sense, right? There's low oxygen. Let's try to get more oxygen to the area. And the presence of lactic acid in the injured injury, which what happens as a byproduct of the injury. To migrate, endothelial cells, cellulinases, and plasminogen activator to degrade the clot and allow cell migration, proliferation, and angiogenesis. When macrophages and other growth factor producing cells are no longer hypoxic or in a lactic acid environment, they stop producing angiogenic factors. So it has its own self-limiting way as it heals. Okay. Fibroplasia and granulation tissue formation. This is type 3 collagen now. New tissue formation. Fibroblasts are the main cells that lay down collagen matrix in the injury. This collagen matrix is going to be very important to permanent injuries and pain. Granulation tissue consists of new blood cells, fibroblasts, inflammatory cells, endothelial cells, myofibroblasts, and the components of a new provisional extracellular matrix. A lot of big words in there. What's the important word? Matrix. Fibroblasts begin entering the injury 2 to 5 days after the injury as the inflammatory phase is ending, and their numbers peak at 1 to 2 weeks post-injury. By the end of the first week, fibroblasts are the main cells in the injury. Fibroblast ends 2 to 4 weeks after the injury. Fibroblasts are the main cells that lay down collagen matrix in the injury site. Fibroblasts are from the adjacent uninjured tissue or from blood-borne circulating adult stem cell precursors. Initially, fibroblasts utilize fibrin cross-linking fibers to migrate across the injury, subsequently adhering to fibronectin. This matrix is going to be real important relative to spinal biomechanics and pain. Fibroblasts then deposit ground substance into the injury and later collagen, which they can adhere to for migration. Granulation tissue functions as rudimentary tissues and begins to appear in the injury during the inflammatory phase. 2 to 5 days post-injury and continues to grow until the injury is recovered. See, it's a layover. It's not black or white. It's layover. Granulation tissue consists of new blood vessels, fibroblasts, inflammatory cells, endothelial cells, myofibroblasts, and the components of a new provisional extracellular matrix. A new provisional extracellular matrix. That's going to be a real issue. The provisional type 3 collagen matrix. Type 3 collagen. Matrix, collagen, scar tissue, is different in composition from the original type 1 collagen matrix in normal tissue, and its components originate from fibroblasts. Fibroblast components include fibronectin, collagen, glycosaminoglycans, elastin, glycoproteins, and proteoglycans. Its main components are fibronectin, hyaluron, which create a very hydrated matrix and facilitate cell migration. So this tissue creates a matrix. Cells are migrating to build on it. Growth factors and fibronectin encourage the proliferation, migration to the injury, and production of collagen matrix by fibroblasts. So it's like building blocks coming in there. We're trying to build it, repair it, patch it. Hypoxia also contributes to fibroblast proliferation and excretion of growth factors. Too little oxygen will inhibit their growth and deposition of collagen matrix components and can lead to excessive fibrotic scarring. So oxygenation during the proliferation is pretty important. Okay, next category in proliferative phase, collagen deposition, tissue strength. Collagen deposition is important because it increases the strength of the injured tissue. Fibroblast's most important duty is the production of collagen. Before collagen is laid down, the only thing holding the injury together is the fibrin and fibronectin clot, which does not provide much resistance to movement or trauma. So this matrix is real important. Cells involved in inflammation, angiogenesis, and connective tissue construction attach to, grow, and differentiate on the collagen matrix laid down by fibroblasts. Type 3 collagen and fibronectin are generally beginning to be produced in appreciable amounts at somewhere between approximately 10 hours and 3 days, depending on the injury. Type 3 collagen deposition peaks at 1 to 3 weeks. They are normally predominating tensile substances until the latter phase of maturation or remodel phase. Let me read that again. They are the predominating tensile substance until the later phase of maturation or the remodel phase. Remodel phase is the third phase, in which they are replaced by stronger type 1. So there is the potential to get back to type 1. Even as fibroblasts are producing new collagen, collagenases and other factors degrade it. Shortly after an injury, synthesis exceeds degradation, so collagen levels in the injury rise. But later, production and degradation become equal, so there is a net collagen gain. So there's overproduction, and then the body's trying to clean it up. Okay. This homeostasis signals the onset of the latter maturation phase or the remodel phase. That's the definition of going into the remodel phase. It's starting to clean it up now. Granulation of the production of new tissue gradually ceases, and fibroblasts decrease in number in the injury once their work is done. Okay, we're done with the proliferative repair phase. Now the physiology of the remodel phase, or maturation phase, strengthening phase. When the levels of collagen production and degradation equalize, the maturation phase of tissue repair begins. During maturation, type 3 collagen, which is prevalent during proliferation, is replaced by type 1. Originally disorganized collagen fibers are rearranged, cross-linked, and aligned along tensile lines. That's going to be a very important therapeutic line right there. The start of the maturation phase can range from 3 weeks to past a year or longer, depending on many factors, including therapy and complicating factors. Okay, we're going to pay attention to this. As the maturation phase progresses, the tensile strength of the injured collagen increases, approaching 50% that of normal tissue by 3 months. And when are your patients leaving?
3 visits.
3 visits. After injury, and ultimately as much as 80% as normal use. They're still in a major part of the healing phase, and you lost them 2 or 3 months ago. Did you know that?
No, not those specifics.
The phases of injury healing normally progress in a predictable, timely manner. If they do not, healing may progress inappropriately to either a chronic or permanent injury. Okay. You go, wow, how do we convert that into something we can talk to a patient about, and how does that relate to us as chiropractors and therapeutic protocol? Okay, so let's dumb it down now, right? Here we go. So on that board, you're going to have the inflammation phase. You're going to have the repair. And you're going to have the remodel. That's the 3 phases of healing. Now that collagen, that's scar tissue. Okay? Now, 4 things just happened here, or 5 things just happened here. Number 1, when there's an injury, and by the way, this is a trick question. When does this process occur? How many cells does it take before this process occurs? 1 cell, 1,000 cells, or 1,000,000 cells?
Well, 1,000,000.
Huh?
1,000,000.
1. When does the body start healing? If 1 cell is damaged, does the body go into innate and start healing?
But you're going to have
Hold on.
multiple cells.
Hold on.
Right?
So I'm hitting some main points right now. This process happens with 1 damaged cell, not 1,000,000. You go, okay. When does it become relevant to the patient? When does this process, the 3 phases of healing, become relevant to you, the patient, if you're the patient? That's a good generic answer. He said, enough damage do you start to feel it. That's just like a good generic damage. When it starts limiting sensory and motor. Do you care if you have an injury? And let's say there's 1,000 cells that are damaged, but it's not affecting your sensory motor in any way whatsoever. You got active range of motion, overpressure, joint motion, full sensation, nerve, everything's functioning normal. Do you care?
No.
No, you don't care. As a doctor, does it matter to you treating the patient? Kind of a trick question. Well, if it's only once, not that big of a deal. But what happens if you have 2, 3, or 4 of those incidents, and all 4 of them are, by the way, that's called subthreshold. When it's under sensory and motor, that's called subthreshold. So if the patient has a little injury, right, and it's subthreshold and it's once, that happens in your life, it's no big deal, right? What happens if it happens twice? 2 subthresholds. What happens if it happens now 3 times? What happens if it happens 4 times? Is it starting to become a big deal?
It's all in the same area, yeah, of course.
Yeah, what's happening?
Scar tissue.
That's right, it's like an onion effect. Now you're getting layer upon layer upon layer to where eventually those layers become what?
You lose your function.
Threshold.
Okay.
So you can have several and many subthreshold that doesn't affect sensory or motor at all, right? But go ahead and add 10 of them together and now what happens? Right? Some of you guys knows that with age, don't you? Little injury, no big deal, and 20 years later you can't move. Right? That's called, see? Now why is this important? This is going to be real important in your therapeutic protocol. Especially with patients who already have permanent problems coming in. Well, you're not going to be able to help and get rid of that permanent problem, but guess what you are going to be able to do? You're going to help to be able to limit the onion effect, the piling on effect. That's what you're going to be able to do with people who come in who have permanent problems already. That's about 20% of your patients. Okay? All right. Now it depends on the type of tissue also, doesn't it? You got your quads, right? What if there's 1,000 cells that are damaged in the quads? You know, I hit my quad, there's 1,000 cells damaged. Let's damage 1,000 rods in the eye now. Are those very different injuries? Same number of cells, right? Very different injury because of the type of cells that are injured. So it's not just the quantity of cells, it's what? The quality of cell. So we're going to be paying attention to this. Okay? Now, what if you are not even doing the test to detect it? What if you're not even doing the test that's showing this is above threshold? It's affecting sensory and motor, but you're not even doing the test to find it. You're doing the wrong test. And you don't even know it. Is that possible? Yeah, that's kind of what's going on right now also. You're not even doing the tests that are showing this. So you don't even know they have this because you're doing active range of motion and you're doing static x-rays. Any of you guys do dynamic x-rays as part of your standard protocol? You just missed one of the most important tests of the human being in joint dysfunction. You just did the wrong test. Any of you quantify overpressure range of motion? You just missed the high sensitivity test. Any of you evaluate motor unit joint dysfunction with motion studies? You just missed the highest sensitivity test for spinal injuries. What did I just tell you earlier? You're not doing the 3 most common tests that actually show the problem. You're doing active range of motion, static x-rays, and so you've got little to nothing, and the patient goes. A lot of times they still have problems. They're just leaving because you're not managing, and they're still in the 3 phases of healing because you didn't even do the test to see the problem. What would you call that?
Incompetent?
Let's leave it at that. Let's just say that's not good, is it? Okay, so here we go. Let's dumb this down, okay? So here's what we want to do. First, we have to know the basics of the 3 phases of healing, or we won't even know why we're doing the therapy we're doing, or why are we doing what we're doing if you don't even know about granulation, matrix, right? Type 1, type 2. What's the effect on the patient? That's the first thing we've got to do. Second thing, what are the tests? Well, what does it matter if you're not even doing the tests that show it? You just missed out again. So you got to do the right test. That's called high sensitivity, high probability diagnostics. Okay? So we're going to learn to do high sensitivity, high probability diagnostics, and we're going to quantify it. Why do we have to quantify it? Right. That always tells us if the patient's getting better, worse, staying the same, or they get MMI and they end up with a permanent injury to some degree the rest of their life. That's why we have to quantify it. Okay? So here we go. What happens in this phase here? There's what's called hyperinnervation, reinnervation. Anytime there's an injury, let's do the nerve components first. Anytime there's an injury, that includes how many cells? 1. Does innate only kick in when 1,000 cells are injured? Do you see how ridiculous that is now? No, it happens when the very first cell is damaged, okay? The question to you from a physician standpoint is what? Is it above threshold? Is it affecting sensory or motor? And the same with the patient. Is it affecting sensory or motor? Right? Their senses. Touch, smell, sight, hearing, movements, all that. Okay? So one thing happens with the nerves is there's what's called hyperinnervation, reinnervation. We just read that. What does that mean? Anytime there's cell damage, those nerves go in there. When that damage, what creates the nerves? What do we say creates those nerves?
Stem cells.
Stem cells. Hyperinnervation, reinnervation. There's an increase in the number of peripheral nerves that goes into the same quantitative tissue. Is that important? Yeah, that's going to be important. Number 2. The cells fire at a lower threshold. You guys know this. You injure yourself prior to injury, like say prior to injuring your thumb, you could have touched it, no big deal. You injure your thumb, you touch it, it's like, oh, hurts more. It's easier to feel the pain, right? The nerve cells fire at a lower level. That's normal. That's what happens. That's part of the healing process.
This is in the repair phase?
No. Right now, I'm going into what's happening to the tissue damage.
Okay.
This is what's happening. We're not even going through the phases yet.
Okay.
We're just going, the tissue's damaged, here it comes. This is what's happening. And then to what degree. Now, your job as a physician, the patient comes in, they don't know all this. Why do they come in? Because they have pain and restrictions. What's the top 3 symptoms why patients come to a chiropractor? Number 1 is pain. Number 2 is muscle spasms. Number 3 is what? Restricted motion with pain.
Loss of function fits in there too.
That's restricted motion with pain. Okay, that's the top 3 symptoms why people come to chiropractors.
Yeah.
What were the top 3 gateways?
Well,
Back pain, neck pain, headaches. That was 84%. Extreme neuromusculoskeletal nerve extremities was the other one. And arthritis is 1 out of 5 patients. Arthritis is the highest disability in the United States. It affects 1 in 5 people. That's joint pain. You think chiropractors might be good with treating joint pain at different degrees of that phase? In other words, how much of a potential market is this?
It's huge.
It's huge. It's huge. They're just not looking to go to chiropractors. They're passing your office every day.
Well,
Okay, so those cells come in. Do they fire at normal rates? Does it take a lot more motion and pressure for them to fire? No, they're way more sensitive. They fire quicker. Now, what does that mean to the patient? If the nerves fire quicker, what does that mean to the patient?
it hurts more.
It hurts when they do normal activities. What does this mean to the patient? If there's an increase in the number of nerves, hyperinnervation, reinnervation, what does that mean to the patient? In other words, there's more nerves in the same confined area. What happens now?
It hurts.
What happens to the patient when they move?
It hurts.
What happens to those increased number of nerves?
There's a lower threshold. So that
No, I'm not there yet. You're here. I'm here. Don't go here. Keep them separate. I'm here. Huh? Well, it's going to increase the likelihood of pain. Why? Because I have more nerves in the same area.
Right.
So if I have an increased number of nerves here, and let's say there's no pain. Now I do this. I'm doing contractile, tensive forces. And now I have more nerves there. Forget that they're even firing earlier. Forget that. Do you see what I'm doing here? I'm just saying, I just have more nerves there. Now, in the same volume of area, I'm going to tract it. So what's happening to that area? It's compressing. It's tensile strength and compressive when you move, right?
Yeah.
When you move, it's compressive tensile forces, right? Okay? What's happening to that tissue? So if I have, let's say there was only 5 nerves before, now there's 100. Now you're going to compress it and extend it. Did I just increase, decrease, or keep the same the likelihood of pain?
You increased it.
Do you get my point? That's what's going on. That's another source of pain. I'm sharing with you the common sources of pain when patients heal wrong with permanent problems.
It's easier for nerves to get caught.
Now, you guys that are doing personal injury, you should know this. This is personal injury. But you're telling me you do personal injury. You don't even evaluate joint motion. You don't do overpressure. You don't do dynamics. You don't know hyperinnervation, innervation. You don't know nerve firing, and you don't know the 3 phases of healing, but you do personal injury. That's the kind of clients I get coming to me and they say they do personal injury. No, you don't know personal injury. You're treating patients with generic, low sensitivity, low relevancy diagnostics is what you're doing. And you're just getting paid more for it. That's all you're doing. That's not personal injury. Okay, can you see how can you now explain a cause of pain right here to your family member? If this heals wrong, there's an increased number of nerves in that injured area, and it goes to MMI. It heals wrong. In other words, it's permanent. That way the rest of their life. Can you see why when they do XYZ and they compress that tissue, they're going to have pain? Just from that alone. Okay, let's go to number 2. Let's say it heals wrong with lower sensitivity, right? MMI heals with lower sensitivity. Patient goes to do their what? Activities of daily living, functional capacity, activities of daily living. They used to be able to do this with no pain, right? But now they go here and it starts getting painful. They can't go from here to here. What's happening here? The nerves are firing quicker. So before the injury, I could go from here to here and they wouldn't fire. I didn't have any pain. But now they healed and they fire at a quicker rate. So now when I do this, it starts hurting. And it starts hurting more the further I go. You guys have had patients like this, right? Okay. This is why people have pain and restrictions at MMI. This is what I testify into court on permanent problems routinely in personal injury cases. This is what gives impairment ratings. You're not even given impairment ratings, are you? No. But you do personal injury. Do you understand how you're not doing personal injury? You're doing generic therapeutic protocols and you're getting paid more. That's all you're doing. Number 3. Those nerves, what did we just read in there? Those nerves can get trapped in what? The matrix. What was the matrix? The collagen. Remember the repair phase? The collagen comes in there, lays down the matrix. Remember that? Randomly, just lays it down in the repair phase. Remember this was called the proliferation phase? It's proliferating what? Type 3 collagen. It's laying down the matrix, the substructure to create strength, right? What's the possibility of these nerves getting trapped in that matrix? High. High. Matter of fact, that's the number 1 cause of failed back surgery. It's not that the surgery didn't work. The scar tissue, the peripheral regenerative nerves, that there's an increase in the number of nerves that fire at a lower level, get trapped in the scar tissue. That's the number 1 cause of failed back surgery. That's why they're trying to decrease the scarring as much as possible and using lasers and micro incisions. That's what all that's about. Pretty neat stuff, isn't it? Starting to feel pretty cool about being a chiropractor, isn't it? It's like, wow, this is pretty cool. We have a direct impact on all this stuff and what we do. Okay, that's another source. So let's say it heals that way. So you have this matrix that goes in there, and by the way, it goes in there randomly. Nerves are in there and they fire lower. That's a source. And then it heals permanently that way. It's an MMI. Done. Now we have a permanent problem to some degree. Now the patient, when they try to heal and they try to move all the way, they can't even do it. They can't even move all the way in that plane of motion anymore. And that's one of the reasons why. Is this not what you're trying to stop as a physician? Your therapeutic protocol is to get all this back to normal before it goes to MMI, is it not? That's what you're trying to do. Okay, these are the neurological components. There's only one other reason for pain, Another reason is the phantom leg or phantom armor leg syndrome. But we're not going to go into that. That's a whole different type of physiology, and that doesn't affect what we're doing. That's like when amputees, still have pain in their arms. So that's one source of pain. What's the other source of pain? We just talked about it earlier.
It's in the fluid.
Inflammation.
Yeah.
What's causing pain due to inflammation?
What's the acid level?
Abnormal pH balance. That's why we're trying to control inflammation. So you got inflammation. So how many sources of pain do we have neurologically? You got inflammation, trying to control inflammation. Are you going to try to do some therapeutics to affect inflammation?
Yeah, absolutely.
Are you going to be able to quantify and evaluate inflammation?
Probably not.
What are the 5 components of inflammation? You ever heard of red,
Swelling.
puffy, swelling?
Tenderness.
Remember all that stuff?
Yeah.
You're telling me you can't quantify if it's red or if it's tender or if it's puffy?
Sure.
You can't, you're telling me you don't do that?
It's only 0 to 12 hours though? 0 to 7
Hang tight.
hours?
That's in the school books.
Uh,
That's not the real world though. Okay. So now we go to the collagen. What did it say about the collagen? It's type 3 collagen. It's only
50%.
70% is strong. Now, why did I pick 70%? Did it say 70%?
It's like 50, right? And then it changed to type 1 and then it became 70?
It varied, right?
Yeah.
So why did I say 70?
Somewhere in the middle.
It's average and it's for marketing purposes. You're right. I'm just trying to communicate this what? Simply. You're right. All this overlaps to different degrees, but to communicate it, you gotta make definitions. That's like the time frame of this. All of this lasts 3 to 4 days, right? 72 hours. But that's if the irritant is no longer there. How many people are static and never move after 4 days? That's why it's not real. That's why what you said isn't real.
Yeah, but you ice it, you take NSA.
How many times do we still see inflammation 2, 3, 4, 5 weeks later?
Yeah.
And that's from the original injury. And then sometimes what happens 2, 3 weeks later, they do dynamic motion. And what do?
Re-injury.
Re-injury. Now what happened to those cells? Are those cells now at the same level of the 4 weeks earlier cells? Or are they starting here now?
They're starting over.
Thank you.
Yeah.
You see how this overlaps? It's not black or white corridors. So how are you going to know what to do? Your diagnostics relative to the injury. Well, what's showing up with their diagnostics? Are you doing high sensitivity diagnostics and are you picking it up? That's what your therapeutic protocol should be based on. If you're not finding any source of pain, the patient doesn't have any pain, you can't re-exacerbate the pain. Should you be doing any therapy to decrease pain? No. See how that works? But what if you're not even doing the tests that show pain? What if you're just looking at the patient statically, goes, I don't have any pain, and they're static? Oh, but you didn't evaluate them when they were moving. And then you didn't evaluate them when they were moving under stress. And then you didn't evaluate them when they were moving over pressure. And then you didn't evaluate the spine with motion dynamics to see if they're having altered pathological joint motion. So you didn't even do 4 of the 5 tests to see that causes pain or dysfunction. You just evaluate them in neutral position. Does that sound like you're doing a good job as a physician? Or does it just sound like you missed a whole hell of a lot?
Bad schooling.
Why? We don't live static world.
Right.
Everything you do has to be evaluated dynamically, not statically. And so, yeah, they'll re-irritate themselves 2, 3, 4. That's called a re-exacerbation, and it's real common. So those are all new cells that started over right here. But I still have these other cells from 4 weeks ago that are in this phase. And then 4, 5, 6 weeks later, they re-injure themselves. Do I now have potentially a whole group of cells that are in the inflammation phase, a group of cells in the repair phase, and a group of cells in the remodel phase? Yes, because it's not black or white. And how are you going to know what to do? Your diagnostics. You're going to evaluate them. Do they have any pain? Do they have any tenderness? and you're going to do high sensitivity testing, you're not just going to do a neutral test, them standing neutral, because nobody lives neutral. That's the first place they'll be normal. Don't have them move, stand neutral and ask them, do you have any pain? That's the first place that'll clear up. What's the last place that'll clear up? End range, not just end range of motion, active range of motion, overpressure, joint motion, abnormal pathological spinal biomechanics. Because if all of that's normal, but they have abnormal pathological spinal biomechanics, what do I know is going to come back real fast? Pain. Pain and muscle spasms and restrictions. See how it works? Where along that timeline are you evaluating them? Do you get my point? Here's the timeline to MMI. From the beginning of the injury to MMI. You guys are just evaluating them right here diagnostically. Gross range, static motion, how do you feel? Gross range of motion, dermatomes, reflexes, that's what you're doing. You're just right here. You're not even evaluating them under stress dynamics for sensory and motor and putting it into which phase of healing they're in. So you're missing all the findings. And then what happens? Well, that's happening. All three phases are healing, whether you like it or not. And then they end up what? They end up at MMI. They end up at MMI with permanent pain and restrictions because of who? Because of you. Because you didn't do the test, you didn't do the therapy to help minimize it, to try to prevent it and get it subthreshold before MMI. So you're done with care, they quit care, and 6 months later they can't move their arm or their neck in full range of motion with pressure. And you don't think you were the problem. Does that sound ethical, moral, or fair to you? Is that how you would want your wife, your mother, or father be treated by their physician? If it's not okay for that, why is it okay for you? Do you get my point? Okay. Why is the tissue only 70? This is type 3, type 1, right? This is not type 1, right?
It changes back into type 1.
Hold on. Maybe. It doesn't naturally.
What's the signal?
Hold on. Why is this only 70? So now you know why I said 70%, right? Could be 80, could be 40. I just took the average because it's easy to communicate 70. Okay? What makes this weak? Is it the quality of the tissue or the structure of the tissue?
Structure.
It's the structure. Here's what makes it weak. How does it lay down the matrix? Collagen fibers are laid down like what?
Random, right?
Random. Now watch this. I'm going to pull this way and this way. In other words, I'm going to move, pick up my kid, whatever, okay? I'm going to have a certain amount of strength here and here when I pull. Okay? Now, let's say these are 10 fibers. I'm going to do the same 10 fibers, and this time I'm going to put them like this. They're all in line. Now I'm going to pull. How much stronger are these 10 fibers? In other words, if I took 10 pieces of thread and I randomly aligned this way and I pulled here and here, how easy would it be to bust 2 or 3 of those thread lines?
Right. The ones lined up.
This is what happens with reexacerbations. What I'm covering with you right now is why people have reexacerbations. Okay? So, when the collagen is aligned along what? You got chiropractors, it's known as what?
The tensile line.
Tensile line of drive. Right? You see this in the hip, right? With the bone matrix. In the bone, it's called Wolff's Law, right? Right? In soft tissue, it's called what? Same thing happens with soft tissue, right? Hodges Law.
Hodges.
Right. You guys know you can look at the matrix of the femur, and it's the bone is in alignment with the stress, right?
Yeah.
Well, the same thing happens with tissue, your spine.
The tendons.
Yeah, all of it, all the soft tissue. It's called Hodges Law. So it's the same thing with tissue as opposed to Wolff's Law and bone. Now, I got those 10 pieces of thread, and they're a random matrix, because that's normally what happens. I pull 2 or 3, how easy is it for it to snap? That's called a re-injury. Now, let's say I line them and I go to the same tensile strength. I got all 10 threads now, and I apply the same amount of force. Are any of them going to snap?
Most likely.
No. How much more force can I now pull on them if I put all 10 of those in a line as opposed to only 2 or 3 now? How much stronger is it? That's what your body's naturally doing, right? Okay. So what makes this a line? What makes the matrix go from this to this?
Stress.
And what causes stress therapeutically as a chiropractor?
And adjustment.
An adjustment. An adjustment. In the line of drive, when you adjust somebody, you're creating, it's mechanical energy that's going into the line of drive that's stimulating the cells, right? These cells stimulate in an electrical response, right? Positive and electrical responses create bone growth or resorption, tissue growth or resorption, right? An alignment. So the stress, the adjustment in the line of drive starts taking this random tissue and starts lining it up while it's in the repair and remodel phase. So if you can get to the patient before they've reached MMI and this becomes permanent, because that's your goal, right? Your goal right here and here is to increase this alignment because it increases the strength, which decreases the likelihood of the person having a permanent problem the rest of their life and re-exacerbations. But if you're losing them by the second or third visit, they're not even getting it. Now they end up permanent to some degree. Where is the greatest, what causes that? The piezoelectric effect. What's the piezoelectric effect? Mechanical energy, boom, we adjust them, high velocity, right? Low amplitude, high amplitude, low velocity, or high velocity, low amplitude. We adjust them, boom, boom, causes stress. Which range of motion does it cause stress in? Active, passive, or joint motion? When you adjust somebody, which ranges of motion are you going into? All of them. You're going past active, right? You're going past overpressure, right? You're going into the paraphysiological joint space, aren't you? You're going into all 3. You're affecting active, passive, and joint, all 3 of them. And which one has the greatest impact? Which one is most important therapeutically? Active, passive, or joint motion?
Joint motion.
Joint motion. Why?
Because it's the deepest.
That's the fulcrum. You said deepest, fulcrum. It's the fulcrum. It's the joint motion that gives the greatest impact. As an example, you did therapy. And let's say your therapy only included 10 degrees of active range of motion through the 3 phases of healing. You just did like this. You just had them do that. How effective is that going to be versus a dynamic motion with regularity that takes them from here to here to here and into the paraphysiological joint space? Can you see the difference? It's night and day difference in it. In other words, 80% of it is in the joint motion. 80% of the healing is in the joint motion. Who does overpressure joint motion? What profession?
Chiropractors and physical therapists.
Let me finish the question. What profession is the only profession that does active, passive, and joint motion in the repair or the remodel phase? Chiropractor.
It's us, right?
Just chiropractors. Physical therapies don't. You where physical therapists don't even do overpressure range of motion? I had an accident a year ago. Did they do overpressure range of motion with my shoulder? No. Did they do joint motion? No. They just did active range of motion and strength. That was it. I wasn't getting any better.
You're in the remodel.
I asked them if they could start doing overpressure motion, and I didn't want them to do joint motion because they don't know joint motion, so guess who I went to for the joint motion? The chiropractor. Yeah. But I knew what was more important for me to heal back to normal. a physical therapist just getting me to move like this, or a chiropractor that takes me through active, passive, and joint motion? What carries the most impact physiologically? What has the greatest mechanical effect? Because remember, it's the piezoelectric effect. Mechanical does what? Stimulates what? You guys are familiar with the piezoelectric effect? That's what causes the effects in soft tissue with the adjustment.
Got it.
Okay? The gate theory is what affects pain. The piezoelectric effect is what affects soft tissue with the adjustment. You should know those. Especially if you're doing what you call personal injury.
And that's what.
Remember that personal injury thing you said you were doing?
Yeah.
You know, when you get on the stand and you write this in your narrative report, remember you should be able to talk about stuff like this? That's called personal injury. So, you get mechanical force. Does it have as great of impact just in a little bit of active range of motion? No. Overpressure? A little more. End of joint motion, paraphysiological joint space? Definitely. That's where it has the greatest impact. Then what happens? Boom! Sends an electrical signal. What's the electrical signal say to the tissue to do?
Calm down, right?
Not nerves, soft tissue. Hodge's law or Wolff's law with Wolff's law, it tells it to what?
It's the stress line.
Grow, yeah. Get stronger in that line. With Hodge's tissue, it does the same thing. It says get stronger. In other words, lay down the matrix, get this more in line with this. It's the piezoelectric effect. That's what you're doing when you're adjusting the patient. You're trying to minimize this as much as possible to get this. You're trying to do this to increase the strength of the tissue before they reach MMI so they don't have a permanent problem to some degree the rest of their life. In other words, they're stuck at doing this. They can no longer do this anymore the rest of their life. But they can do this. But they can't do this. That's what happens with the strength. Now, number 5, next one is it's only 70% as elastic. So what does that mean to the patient if that tissue that's injured heals, goes to MMI, and it's only 70% as elastic?
So you're going to lose range of motion.
Bingo. Which range of motion will you lose first?
Active.
No.
Passive.
No.
Dynamic.
Joint motion. What always moves first? Anytime you move, what always moves first?
The fulcrum.
The fulcrum.
Right.
Is the fulcrum active?
No.
No. Is it overpressure? No. It's joint motion. That's what moves first. In other words, this can't move until what moves? This. This has to move before that's going to move. This is active range of motion. Before this happens, what has to move first? The fulcrum. Are you with me?
Yeah.
So, that collagen heals wrong. It's not as elastic. Could be subthreshold, right? If it's subthreshold, no big deal, right? Unless it starts layering, right? Multiple injuries, right? But if it's subthreshold, no big deal. So one of the therapeutic things we're trying to do as physicians is decrease the potential of them having non-elastic tissue when they reach MMI. You see how we're doing that? Are you evaluating it and are you therapeutically doing it right now? No. Are you evaluating this and therapeutically treating it right now? No. Are you evaluating this and treating it therapeutically right now? No. You didn't know this existed. You were basing your care on symptom care and pain, and the communication was bad, and we know it was bad because patients were leaving left and right. And it could be worse than bad. It could be a paradigm shift. Right? They come in for back pain, and you start pushing the button to the liver. And the liver lights up. And you think that's cool. And they want to get the hell out of there because they don't buy computers from Taco Bell. Is this making sense? Okay. All right. So here's the here's the 3 phases of healing in simplicity. There's the inflammation, the repair, the remodel. We're going to put timelines on these. Are there timelines? Not really, because they could re-injure themselves and you have a whole new sliding scale of healing, right?
It's going to vary based on the patient.
We got, yeah. And the patient's what? Biomarkers. What are biomarkers? Tests. But what if you're not doing the right tests? You'll just totally miss it. You're not even checking for tenderness, you missed it. You're not checking for muscle spasm, you missed it. You're not checking for inflammation, you missed it. In other words, you're not even doing the right test. You're just checking active range of motion or in a static position. You just missed 95% of the problems with chiropractic patients. Our patients have joint dysfunction problems, not active range of motion problems. They got overpressure joint motion problems. So you got to start narrowing your test and having be way more specific. And then you got to start quantifying. Because that's where the problems are. It's not in a neutral position or the person just moving in active range of motion a little bit under no stress. Or they heal wrong. This is what happens to some degree at MMI. How much? Could be a little, could be a lot, I don't know. That's what you just did to the patient. You helped them heal wrong. Okay. So generally what we do, to simplify this, we won't talk about the hyperinnervation, reinnervation too much at all. We're typically going to go 2 and 2. So we'll put 2 up here on the board. We'll go, when your body heals, the nerves that naturally come in there, they fire at a lower level. Now, does chiropractic help that? Does physical medicine take a nerve that fires at a lower level and increase the threshold of that level? Does physical medicine do that? Yeah, it does. You hit your thumb. Wham! What do? What's the first thing you do?
Shake it.
You grab it. Okay, when you shake it, does that, how's that decrease? What's that called? Why is that decreasing the pain?
Because you're firing proprioceptive.
It's called the gate theory.
Gate. Right.
You grab it. Why do you grab it? And it feels better when you grab it and compress it, right? Why? They're not firing anymore. So when you physically adjust a patient, in other words, this is tender, but I come in here every day and I go, that gets less sensitive the more times I come in and do it, doesn't it? Yeah. I'm not talking about damaging the tissue. I'm just coming in and stimulate. I come in 1, 2, 3, 4 weeks later, and it doesn't take as much pressure, and I don't feel it, do I? So does physical medicine decrease or increase the firing of the nerve? Yeah. I'm talking about without damaging tissue. If you go in there and damage tissue, yeah, it's going to cause more sensitivity quicker. I'm just talking about the mechanoreceptors, stimulating the no damage, stimulating the mechanoreceptors periodically over time. It'll elevate and decrease them firing at a lower level. Physical medicine. But remember, you got 3 ranges of motion, not 1. So if you're only treating them in active range of motion, is it possible to leave these firing in the overpressure joint motion at a lower level and then them healing permanently that way? That's exactly what happens.
They get physical therapy.
That's exactly what happens. That's exactly what happens. They end up with permanent problems, pain and discomfort. What's the main reason? Most people are taking Motrin, ibuprofen, the number 1 medications over drugs, and they have joint dysfunction, arthritis. Why is arthritis the number 1 disability? Is because they have injuries that never had physical medicine in all 3 ranges of motion, specifically what is the most important therapeutically to decrease the likelihood of these permanent injuries.
Joint motion.
Physical joint motion in the repair phase. That is what has the highest, most effective potential for increasing the nerve, decreasing the nerve sensitivity, decreasing the likelihood of the nerves getting trapped. Why do they not get trapped? Because we're aligning the collagen now. We're decreasing the likelihood of these nerves getting trapped, which decreases the likelihood of them having pain when they start stressing their different movements down the road. And then we want to do some active therapy here to increase the strength. So the physical medicine, because we don't want to just do physical medicine and active range of motion, do we? Because now they'll heal with positive overpressure and positive joint motion. Right. Some of you guys have that right now. You have old injuries where your active range of motion is probably pretty good, but as soon as you go in a little bit of overpressure or joint motion, you're like, oh, stay away from that. Don't you, some of you guys have some old injuries like that? See? It would have been better off if it would have got physical medicine and all three range of motion during the repair phase of healing. It may not even have been permanent. So this is what requires physical medicine. We just want some resistance treating here. That's what TheraBands. TheraBands. Resistance treating. Cervical traction. That's what this is. We just want a little bit. We're not trying to make Hercules. Okay? We want resistance. Why? The mechanical effect,
Elasticity, right?
the piezoelectric effect, Hodge's law, starts increasing the strength and the alignment of the tissue as much as possible in the remodel phase before they hit MMI. Because once they hit MMI, it's like wet concrete. It's dried. It's done. You got a window and that's it.
And it's
That's
for everybody?
This is why only after there's 1,000 cells that have been injured, not the first cell.
Gotcha.
You get my point?
Smart ass.
Because human innate doesn't happen until only 1,000 cells are injured.
Right.
Okay. Okay. So is it is it above threshold? Well, you're not even doing the test to see if it's above threshold, are you? You're not even checking for it. But even if you do the test, is it still going to happen? Is this still going to heal this way? Yeah, this is how we heal. So even if you did the test, would I still want to do a little bit of resistance exercise knowing that this is what happens anyway? Even if it was just a little bit, to get a little bit of resistance exercise in there? Because I know this is what's going to happen. Or this only happens with 1,000 cells. And it never goes into the remodel phase. You see how not smart that is? So, yeah, you want to do the test to see if they have it, but the test doesn't involve static, right? Don't you need to test them dynamically if you're going to treat them dynamically? If you want them to be dynamically normal, right? Okay. And then what about elastic? Same thing. Should we do some kind of stretching knowing that this is how they heal? This type 3 collagen is only going to be 75% as elastic when it heals. Should we not do some type of elastic stretching through active, passive, or joint motion? If we know that's how the body heals.
100%.
Thank you. There's your therapeutic protocol. That's what you should be doing as chiropractors. You should be treating for the inflammation phase, documenting the biomarkers, doing the high sensitivity test and quantifying them. In other words, doing the right test. Then you should be treating them for the repair phase. What's the goal here, therapeutically? To decrease pain, inflammation, and muscle spasms. You're going to have certain tests that are going to show those more than others, and then you're going to quantify them, and that'll tell you if it's getting better, worse, staying the same. Then the patient's going to go into the repair phase. What's the goal? What's the therapeutic goal here? It's to increase active, passive, and joint motion. There's 3 ranges of motion, not 1. And which one is the absolute most important?
Joint motion.
The fulcrum. And only chiropractic affects that joint motion. So yes, but what if you're not even doing the tests that evaluate joint motion? What's the single test that evaluates joint motion the best?
Overpressure at end range?
I said the best. Those are definitely tests that affect it. Motion x-rays, especially with the spine. Motion x-rays. Are those bones moving normal or abnormal? If they're moving abnormal, what do I know is going to happen to that patient? Even if they do or don't have any pain or discomfort whatsoever, what am I guaranteed to know is going to happen to that patient? It's going to come back. Now you as chiropractors know that as what? A fixation. And every now and then, you just feel a higher need to get adjusted. You kind of start feeling more pain and discomfort in your neck or your back. You're like, man, I need an adjustment. Isn't that what you say as chiropractors? See, you notice it as a fixation when it's joint motion abnormally. And then what happens when you leave that joint motion alone? That pain and discomfort, you don't get it treated therapeutically, what happens? Does it stay the same or does it migrate and get a little worse? Does it start running into overpressure? Does it start eating into overpressure? Yeah, and then you leave it alone. Then what happens?
You lose range of motion.
Which range of motion? The end or the beginning?
The end.
The end. You see how this works? So you have this abnormal motion. You leave it alone. That abnormal creates abnormal pathomechanics, mechanoreceptors, tissue, muscles, all that. Pain, muscle spasm, tightness. You guys know that as a fixation. You get adjusted and you feel better. The people who don't, it gets worse and worse and worse. Causes more pain more often, more intensity, more frequency. Then it starts eating into more of their activities. Then it starts eating into overpressure. Now when they go into overpressure, they start feeling it. And then as it gets worse and worse, now it starts hurting at the end of active range of motion. And as it gets worse and worse, it starts eating a little bit more of in the active range of motion. And then what do we do as patients when we don't know any better? How do we treat that when we don't know any better? What's the first thing we'll do?
Take some medicine.
Not first. That's not the first thing we'll do. What's the first thing we'll do when we have pain or restrictions in joint motion and we don't know any better? We'll stop doing that motion. If it hurts when you do this, don't do that. That's the first thing we'll do. What's the next thing we'll do? Rest. What's the next thing we'll do? What's the hierarchy of therapy for that, for a normal person? First, they won't do the motion. Next, they'll do what?
Take it.
Maybe an ice pack, therapy, brace. Then they'll do what?
Yeah, take a pill.
Over-the-counter medication, ibuprofen. And how many millions and millions of people are doing that every day with joint dysfunction that have never been to a chiropractor, and that's why they have joint dysfunction. And then it gets worse, and then what do? Then they go to prescription.
Yeah, they call their doctor.
And they go to prescription.
Right.
And then as it gets worse, then they do what?
Shoot heroin.
Then they'll have surgery to some degree. And this can happen over 5, 10, 15, 20 years, right? Right? All because they didn't get chiropractic treatment and active passive joint motion to minimize or possibly eliminate the possibility of pathologically altered joint motion when they reached MMI. They came to you. You just did a little bit of active range of motion. They felt a little better and they left. You didn't know any better. They didn't know any better. So they end up healing what? They heal wrong. Through all 3 phases of healing, they now heal wrong. And that whole cycle kicks in. And that's why you have millions and millions of people on ibuprofen, Motrin, Tylenol, back pain, neck pain. But they're not going to the chiropractor because you're not going to buy a computer from who? Taco Bell.
67% bad. What did you say?
And you're never going to hear what I just shared with you in the last 2 hours in chiropractic. You haven't heard it, and you're never going to hear it again. Have you heard of anything of what I've covered in the last 10, 20 years you've been practicing? Have you? Have you? Have you? Thank you. How much sense does this make tonight? This is what your care is based on. This is why you do it. So what we're going to start with next is we're going to go, well, what are the common tests here, high sensitivity tests, that are going to tell us if they have inflammation? And then you're going to do what? You're going to do the therapies that decrease pain and inflammation. And then you're going to check for muscle spasms. And if they have muscle spasms, you're going to want to grade it. And then you're going to want to do some therapies that help decrease muscle spasms. Does that make sense? And then as they come into the repair phase, we're going to want to do the tests that check their active, passive, and joint motion. Not just one. And then we're going to want to quantify it. Then you're going to want to do the therapies that increase their active, passive, and their joint motion as much as possible before they hit MMI and it becomes permanently restricted. How much sense does this make? And you're just going to quantify it. You're going to do re-exams every 12 visits, and you're just going to measure it. Are they getting better, the same, or that's it? They're at MMI. And then you already know this is what's happening. Then you're going to come over here, and you're going to measure elasticity and strength. Then you're going to quantify it. Then you're going to do the therapeutic protocol to help increase the strength as back to as much as normal as possible and the elasticity as much as possible to decrease this person from having a permanent problem to some degree the rest of their life. Because as soon as they get out of this, it's permanent. That's what you're going to do. You're going to educate the patient on how this works. And when they see this, how much sense did it just make to you? If you had an injury, would you want any care less than this with the possibility of now having pain or restrictions the rest of your life? That's what happens with education. Now what's the only two categories they have to deal with? You just accepted the care, didn't you? I just have to consider two other topics. What are they? Money. So now I'm just going to take the money and spread it out. Put it into biweekly payments and make it real small. That sound fair? To where now it's not $3,000, it might be $100 or $200 every 2 weeks. Sound fair? How much likelihood are you now to get to say, yeah, I can't afford 3, but I definitely want the care, but I can't afford 3, but I can handle 150 every 2 weeks. Are you okay with that? And then when you came in here, I didn't have you wait in that waiting room for 20 minutes. You came right in. You went right back and saw the doctor. He only spent about 3 to 5 minutes. He adjusted you, did what he needed to do. You came over to the therapy. You got anywhere from 10 to 20 minutes of therapy. So in 20, no more than 30 minutes, you were out of this office. And you didn't have to wait at all. Are you okay with that? That's how it works. That's how people stay and pay for care. And that's how you help a lot of people and prevent a lot of permanent problems the rest of their life. And it feels damn good. That's what being a chiropractor is about. Not pushing the button to the liver and then leaving after the second visit. And not wanting to send their family back either.